This was a normal day for routine cataract surgery in a 67 years old lady with nothing alarming pre-operatively. Aside from necking the anterior capsule during my paracentesis, I noticed very long insertion of the anterior zonules. This was my first time to see such an abnormality, leaving very small area for capsulorhexis. My first and only worry was how to do a continuous capsulorhexis without extension by bypassing these anteriorly inserted zonules. So very carefully I tried to do my capsulorhexis to get a continuous circular one, thinking that this should be my only problem in such a case. Moving forward, I could get away with a nice circular continuous capsulorhexis. But if I look carefully here with high magnification, you can see that I was stripping the anterior zonules. But again, this did not ring any bells in my head. So carrying on with my technique of hydrodissection, then vertical chopping, normal settings, just looking around for any abnormalities, but not really worried about anything serious as I got my continuous rhexis. Now I start to notice some wobbling of the whole bag, so I decided just to go out carefully with the replacement of viscoelastic to evaluate the situation. I can see that the bag looks intact, but still I'm not comfortable, so evaluation with more injection with viscoelastic, inflating the bag and checking what's wrong. I have left major epinucleus and part of the nucleus. So still trying to dislodge it out of the bag, and then I noticed large area of zonulisis, more than 180 degrees, or that what I thought. Probably it looks there is zonulisis all around, but being in a state of denial, I started to inflate the bag thinking I can go away with this. So I started to try to get the cortical material, epinucleus and nuclear fragments outside of the bag, and thought I could do phacoaspiration for it, preserving the bag, waiting for the help of capsular hooks or capsule tension rings. Obviously, that was not the case, as I could see the whole bag crumpling and not supported with anything. So my concern shifted not to losing any fragments into the vitreous or losing the bag with its contents into the vitreous cavity or disrupting the anterior vitreous face, which was until this moment intact. In spite of what was obvious, I was still hoping I can do something to salvage this bag. So I started inflating the bag, which looked nicely inflating with no vitreous. Trying all the tricks I know to manually remove the residual cortex and fragments while preserving the bag. All after some time looked to go in vain. After all, I had to admit that all my attempts had failed to preserve the bag completely. So I started to do visco-expression of the cortical contents, and then I thought I have to get the whole bag with the contents outside of the eye, and my focus was to keep an intact anterior vitreous face at this point. Checking for any vitreous strands, I could catch one coming from the periphery. So this means I have to start to do anterior vitrectomy with high cutting rate and low vacuum. Now that was the time I should think which type of lens should I use and where to fix it. I thought iris glow lens is a good idea. So I started to inject mycol to get the pupil down and massage the iris from the periphery so as to constrict it a bit more. But oops, I see I got hemorrhage from the iris root that was trickling into the vitreous. So I had to inject more viscoelastic, wait a while, trying to tamponade this hemorrhage that was trickling into the vitreous cavity. So I have to go again with the vitrectomy probe to clean up the vitreous as much as possible. Then injecting more viscoelastic and trying to tease in the pupil to a reasonable size so as to be able to put the iris glow lens. To complicate matters more, as I was having a temporal clear cornea incision and setting temporally, this was really difficult position to mechanically inclinate the lens. So I have to think what to do. So I changed the position of the forceps by enlarging my paracentesis to be able to hold the lens and inclinate the close of the lens properly. So this was successful, but when I looked at the position of the lens, it looked not properly centered. So being not the lucky day, I thought I have to disinclinate the lens again, keeping in mind that I had this hemorrhage from the iris. And then trying to inclinate the lens in a proper position. It was not easy, so I have to do a paracentesis opposite to the area of intended inclination to mechanically make it easier for me to control the inclination of the lens close. Finally, I got the lens in good position. I closed the wound with one suture and left some vitreous hemorrhage, hoping to clear soon. Postoperatively, the vitreous hemorrhage cleared in 10 days, but the intraocular pressure was not controlled by medications, so filtering surgery had to be done. Reviewing literature showed that this case is called long anterior zonules and could be partial or complete and could be associated with increase in intraocular pressure. And there are multiple scenarios that we should learn and better to detect it preoperatively to know what to do. The lesson is that no matter how experienced we are, we will get complications and we will see new disease entities. Thank you for your attention.